start by talking about what advanced care planning actually is. It's a process of thinking and talking and planning about your health care in advance of a time when you can no longer speak for yourself. It's about your future health care, about what matters most to you, what's important, what you value. Some of you may already have an ACP or perhaps started one or perhaps been thinking about starting one, and it always takes such a long time to sort of get there. But for many, this may be the beginning of the process. So ACPs replace what used to be called living wills. In BC, the correct terminology now is advanced care plans. An actual written will, of course, regarding your estate and your assets only comes into effect after your death. But an advanced care plan provides direction while you're still living. Now, Carmen will introduce us to what happens with COVID and highlight the importance of having an ACP. And before she does that, let's just talk a bit about what you're seeing up there. Something to consider, a very interesting statistic. 90% of Canadians believe that it's important to talk about their own and their loved ones' wishes for end-of-life care, but only 30% have done it. Whereas less than 50% of Canadians have prepared wills, and only 1/3 of those are up to date. And so we have to question, what is it? Why is the discrepancy there? And there's a whole lot of reasons for why people think about the importance of something, but just don't get around to doing it. We're hoping that tonight's webinar will give you the initiative that you need in order to start working on your advanced care plan. Carmen. Carmen, you're on mute still.
Sorry about that. Thanks, Joan. I'm just going to share my screen so everybody can see my slides. All right, so first of all, why am I here today? I want to talk about why an ACP is so important, especially in the setting of COVID-19. ACP is all about thinking about what kind of healthcare is acceptable to you and sharing that information with the people you trust most and your healthcare team. COVID-19 is a very dangerous illness that can cause rapid deterioration and death. And what that means is that a patient can rapidly lose their ability to communicate their healthcare wishes. And the last thing you want is your loved ones being uncertain about what type of care you want and them having to live with the stress of making those decisions on your behalf without your guidance. So why is COVID-19 different? Why is it different than the flu and other viruses like the common cold? And why is there so much kind of hoopla about it in the past few months? And why has kind of the world essentially shut down? Well, the first thing is that this virus spreads so quickly. So one person with COVID-19 typically affects 2 other people that they come into contact with. That's different than the flu. The flu, it's kind of a one-to-one. You have the infection, you spread it to one other person. So the spread's just not quite as fast. The other thing that makes COVID-19 different is the hospitalization rate. So 20% of people with COVID-19 are hospitalized, as opposed to the flu, it's only about 2%. So that's a really big difference there. So just that statistic alone, we know that people get much more sick needing to be in the hospital with COVID-19. And the third thing that makes COVID-19 so much different is the mortality rate, so the death rate. I know this is an evolving discussion. We're learning more and more about COVID-19 with every day that goes by. But so far, with the statistics and evidence that we have, indicates that the mortality is about 3 to 4% in COVID-19 patients. And what that means in kind of real numbers is for every 100 patients with COVID-19, 3 to 4 of them will die. And this is much higher than the flu, where less than 1 person out of 100 with the flu will die. It's actually 0.001 people will die from the flu out of 100. So that mortality rate is very different. So what are the symptoms of COVID-19? And I'm sure many of you have heard this over and over again, but we're going to go over it again. So most people with COVID-19 only have mild symptoms. So the most typical things we see are fever and a cough, which is typically a dry cough. But we can also see chills, shortness of breath, a sore throat, painful swallowing, runny nose, nasal congestion or loss of smell, headache, muscle aches, feeling tired, losing your appetite, and less commonly kind of gastrointestinal symptoms like diarrhea, nausea, and vomiting. So all of that sounds kind of like a typical cold, typical flu. And so again, why are we worrying about this? If those symptoms, how can those cause hospitalization? Well, it's because there are a portion of people who have COVID-19 that don't just look like this, that don't just have these kind of simple symptoms. They typically develop much more severe and potentially life-threatening complications. And that is why we worry about this disease so much. So what are the severe complications of COVID-19? So I've kind of divided this up into different parts of the body as best as I could. So the first complication that we have been seeing are in the lungs. So there can be a severe bacterial pneumonia, which is bacterial infections in the lungs. So essentially you already have COVID-19 that's affecting your system, and then you get a bacterial infection on top of it that affects the lungs. You can also get a severe lung injury because of all the inflammation in the body that's trying to fight the infection. And this typically affects the lungs, and we call that acute respiratory distress syndrome. And that is essentially, there's so much inflammation in the lungs, they start to fill up with fluid, and you get sick really, really fast. And this is people, there's a 50% death rate in people who just develop acute respiratory distress syndrome. The other thing that can happen with regards to severe complications of COVID-19 is multi-organ failure. So meaning multiple organs in your body can stop working, whether that be your kidneys, your heart, or even your brain. So multi-organ failure can be seen because of sepsis, and sepsis is caused by a widespread bacterial infection. So as I mentioned before, you can get a bacterial infection in the lungs, and if that spreads to the rest of the body and throughout the blood, you can get something called sepsis. And that just means that your blood vessels expand way too much and you don't get enough blood to your vital organs. The other way that you can develop multi-organ failure from COVID-19 is something called a cytokine storm. And what the heck is that? That is a widespread, severe immune reaction. So if you think about what your body is trying to do when you get any kind of infection, including COVID-19, you're trying to fight off that infection. But sometimes your immune system can go overboard, and the proteins that it normally makes to fight infection, it releases way too many at once. And that causes your vital organs to shut down. Another complication that's commonly seen with COVID-19 is the formation of blood clots. So blood clots that can form in the lungs, that's called a pulmonary embolus. Blood clots that develop in the blood vessels that supply blood to the brain, that causes a stroke, or blood clots that affect the blood vessels that provide blood to the heart, and that causes a heart attack. And last but not least, there are many complications that COVID-19 causes with the heart itself, other than what I just mentioned with the blood clots. So it can cause a heart attack, and whether that be because you have underlying heart disease, so maybe you've had a heart attack before, or maybe you haven't, but you have high cholesterol or high blood pressure, diabetes. So the blood vessels that provide blood to your heart to keep it beating are kind of clogged already. And all of a sudden there's this extreme stress with this infection, or maybe there are other COVID-19 complications and your heart just can't deal with it, doesn't get enough blood, you have a heart attack. There can also be, like I mentioned before, a lot of inflammation. This can affect the heart muscle, and that's something that we call the myocarditis. And if your heart is a muscle, so if it is all inflamed, it's not going to be able to pump properly. And this can lead to something called heart failure. And a heart attack can also lead to that as well. So that is when your heart is just not pumping the way that it should. And if your heart isn't pumping as strongly as it should, then the rest of your organs are not going to get enough blood supply. And again, with all of the complications on the heart that I just mentioned, the other thing that can happen is abnormal heart rhythms. So your heart is supposed to do that lub-dub, 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 and what COVID-19 can cause is a totally erratic heart rhythm that does not allow blood flow to the rest of your body. So these are all really scary scenarios, but they do happen with COVID-19. These are the reasons why we worry about this illness. And these are the complications that are killing people. Oops, sorry. So these severe complications, these can happen very quickly, and they can spin out of control very quickly. And people tend to deteriorate if they have these complications within hours. So this isn't a slow process that maybe day to day or week to week we see complications. It is hour by hour. We see people go downhill, unfortunately. And I think that's why having an advanced care plan in this setting is so important, is the complications that I listed before, but just how quickly your health can really change. So the next few slides are some graphic representations about COVID-19 patients. So this graph is showing us that 80% of people with COVID-19 get the simple fever, some cough, they're feeling tired, and they're going to recover, and they're going to recover at home and be just fine. That's a majority of people, 80%. However, there are the 10 to 20% that end up going to the hospital because they are more sick. Of the people that go to the hospital, 80% of them will require routine hospital care. So maybe they're going to need a bit of IV fluids and a bit of oxygen and some physical therapy to help them get strong again, and they go home. Pretty basic care. Unfortunately, there are the 10 to 20% of the hospitalized patients who have to go for much more intensive care. So they go to the intensive care unit, and unfortunately 50%, so half of the patients who go with COVID-19 who go to the ICU die. So of the patients who go to the ICU, what happens to them there? Half of them are going to require life support. And what is life support? That is the breathing tube. We call it, you'll often hear it be called a ventilator. But that is a breathing tube that goes directly down the windpipe and supplies oxygen that way. And I think it's important to keep in mind that this is an invasive way to treat someone's respiratory symptoms and failure. And that people over the age of 70 almost never survive ventilation or life support in this, and younger people who do survive often requires weeks and weeks on the ventilator before they recover. And the average stay on a ventilator in COVID-19 patients is between 10 to 14 days. So how do people who end up on a ventilator do with COVID-19? And the numbers are not great. Unfortunately, 90% of people who end up intubated, so requiring life support, will die. So that is a huge number of people who don't do well on a ventilator. So who is most at risk for having the serious complications of COVID-19 that make us all so worried about this disease. It's people who are older than 60. It's people who have underlying health conditions like heart disease, whether that be high blood pressure, coronary artery disease, so meaning having a heart attack before needing a stent, heart failure. It's patients with diabetes, and it's patients with any conditions that affect their immune system. So things like HIV or other illnesses, like even psoriatic arthritis or rheumatoid arthritis, and you're on therapy to calm down your immune system. So the medications are what make you immunocompromised. All right, so COVID-19, what type of care is acceptable to you in the hospital? It's important to keep in mind that patients with COVID-19 don't have any control over the progression of the virus or the symptoms that they may end up having, but they do have some control over what interventions they want. So these are the different kind of interventions. So I've divided it into non-invasive and invasive. So non-invasive, maybe someone's dehydrated, we give them a bit of IV hydration. Maybe they have that superimposed bacterial infection in the lungs or in the bloodstream, we can give you antibiotics for that. If you have that very severe immune response in the lungs that I talked about called acute respiratory distress syndrome, we would consider you giving steroids to try to calm that down. There are different methods that are non-invasive to have oxygen. So everyone's probably seen either a loved one in the hospital, or you've seen it, on movies or TV, people who have nasal cannula, so oxygen in the nose, or maybe they have oxygen with a mask. The other way to give oxygen is actually with a little bit of pressure. And what that bit of pressure does is helps to keep the lung tubes open. So all those tubes in the lungs that deliver oxygen. So there are a couple of different ways to do that, which are called Airvo, BiPAP, or CPAP. And I'll get into that in a couple of slides. And then the last way is the most invasive type of treatment, which I mentioned before, which is intubation, which we've also called life support and ventilation in this talk. And what that is a tube down the windpipe hooked to a machine that is breathing for you because you cannot breathe on your own. So this is what Airvo looks like. So again, this is a non-invasive way to have oxygen. So this is a device that delivers high flow, warmed and humidified air. It can also deliver humidified oxygen. And the high flow kind of helps to keep the lung tubes open. This is what CPAP or BiPAP look like. So as you can see, it can either be something that covers the nose or something that covers both the nose and mouth. The masks are similar for both CPAP and BiPAP. And what the difference is between those two types of oxygen therapy that give pressure at the same time is that the CPAP gives a continuous pressure to keep the lungs tubes open, while BiPAP actually has two different pressure settings. There's higher pressure for when you take a deep breath in to allow as much oxygen in as possible. And there's a bit of pressure to help get the old air out, to leave more room for new air when you take your next breath. And this is what intubation looks like. So as I mentioned before, you can see a tube that actually goes directly into your windpipe, which is your breathing pipe, so that you're right into the top of the lungs there. So this allows oxygen to be delivered directly to the lungs, and it does require a patient to be sedated. All right. So this is kind of to recap why an advanced care plan is so important in the setting of COVID-19. There's severe COVID-19 is deadly. 50% of those who go to the ICU will die. 90% of those who end up on life support will die. People with severe COVID-19 deteriorate rapidly, leaving no time or ability to devise an ACP, meaning it is up to your loved ones to make decisions for you in a very emotionally challenging situation. And too often in those stressful settings, loved ones will make decisions out of guilt, fear of losing a loved one, or burden of feeling they killed their loved one. Often loved ones find it difficult to think about the quality of your life down the road, because in that moment, it is so stressful and emotionally charged. So please don't let your voice get lost, remain in control of your life, and take the onus off your loved ones. So after all of that very heavy medical and emotional talk, I wanted to tell you all a story to kind of try to bring all of this information together with a real life story. So I encountered a patient who was a COVID-19 suspect who had underlying lung disease, quite severe lung disease, and was an older person who presented with extreme shortness of breath and required not just regular oxygen with the nasal cannula, but ended up needing a face mask to try to help them breathe, and eventually some Airvo. And so the situation was, this person was deteriorating very quickly. So I was very worried they had COVID-19 because their oxygen levels went down and down every hour by hour. And so I knew that I needed to have a very important conversation with this patient while they were still awake and able to have that conversation, because I was worried they were going to pass away, and I needed to know, did they want to be on a ventilator or not, because that's the direction they were heading, or were they okay with the care they were getting, and if it didn't work, to just provide comfort. A lot of big things to talk about. So I had to go get donned in all of my PPE. So I have my goggles on, I have a face mask on, I have my big gown on, my hair is covered, you can't see my face. Not a fun or very warm way to have that conversation. I had to go into a negative pressure room that was very loud because of all the oxygen, and the which is very, very loud. And this patient, unfortunately, was also hard of hearing. So in an environment that is sterile, where you can't see your provider's face, where you are just struggling to take a breath, let alone have a very intense, emotionally charged conversation with someone you just met, you can't hear at baseline, but now we have oxygen, and it was just a less than ideal setting. And thankfully, we got through it, and he was able to tell me, yeah, you know what, I want to see how this goes. I'm going to give this another few hours, but he was okay with not being vented. So his voice got to be heard. I got to talk to his family. I got to invite them in just in case worst case scenario happened. And that worked out well, I would say. But I was so worried that it wasn't going to. It was hard, and it was worrisome that he wasn't going to be able to voice what he wanted. And I think it highlights the importance of knowing what this disease entails, and that if you get really sick from it, knowing what kind of healthcare is acceptable to you at kind of each step of the way, and not waiting until you are in the hospital, potentially needing to get, go to an ICU, get transferred to the city. Have this well thought out. Have it thought out before you get sick. Have it written down and share that with your loved ones, so that you're not in a scenario where you're just trying to focus on your health and getting better, but now you have to have a very difficult conversation when you don't really have a ton of energy to do so, and in a very sterile and less than warm and inviting environment. So that was my experience. Thank you guys for your time, and you'll hear more from me throughout this talk.
Thank you, Carmen. You really sort of laid it out pretty straightforward for us, and around the importance of having an ACP. So I want to talk a little bit about how you get started and how you find a decision maker, someone that can speak for you when you can't. So there's 4 steps that I've outlined in advanced care planning, and they are think, choose, talk, and record. So think, choose, talk, and record. The beginning, of course, is what are your thoughts about end of life? What are your thoughts about dying, approaching end of life? And you need to explore those things that give your life meaning. What makes each day worthwhile? What do you get up for? What do you look forward to in the day? What gives your life, what enriches your life? And then what cultural or spiritual values do you hold, and how important are they to you as you approach end of life? And how would you like those to be honored and respected? Another question to think about is, what abilities can you not live without? Most of us just take for granted the ordinary daily functions of life, but if you couldn't feed yourself, if you were not able to walk, if you could no longer drive, you needed help in toileting, would that make a difference in terms of how you felt about your life? And and then, as Carmen talked about, what life support treatments would you accept or refuse? All the way from simple sedation, antibiotics, to steroids, to being on a ventilator. So the next step then is really having thought that all out, and it doesn't happen overnight. It's a process, it takes time. You think about it, and you may talk about it, and you may write something down and think about it again. But then you need to choose a decision maker, someone who's going to speak for you when you can no longer speak for yourself. So there's some things to consider when you're choosing a decision maker. First of all, you want somebody who knows you well and who's willing to take on the role. It's easy at the beginning to simply say, well, my best friend or my spouse knows me well, but they may not be the person that is willing to take on that role and that responsibility. And then you need to find a person, that same person who you trust to make the decisions for you that honor your wishes and instructions. And that's important because the person that you choose may have different wishes, may have made you different choices for themselves, and may want something different for you, but they're speaking on your behalf, so they must be able to put their own ideas in behind them to think about what it is that you would want and to be able to honor that. And then someone who, again, is calm in a crisis and is able to handle conflict. And that conflict may come up because you have different family members who may have different ideas about what should be done and what mom would want, what dad would want. But you as the decision maker now have to make that decision and go against maybe what some of the family would like. So then, having chosen, there's a couple of things I want to say about decision makers, and that is that in BC, we have 2 types of decision makers. One of them is called a temporary substitute decision maker, and the other is called a healthcare representative. And a representative is an advocate for you, a person that you appoint in a legal written document called a representation agreement. You don't need a lawyer to have that done. You can find all the information and forms that you need in a booklet that's published by the Ministry of Health called My Voice. You can download that booklet from the internet. Or if you don't want to enter into a legal agreement, you can simply choose someone and appoint them to speak for you without having a formal agreement. Now, in the meantime, if you've not asked somebody to be your decision maker and you find yourself in a situation where you can no longer speak for yourself, your doctor will choose someone to speak for you. And that person is chosen from a list of 9 individuals determined by BC law. The list starts with your spouse, It's followed by an adult son or daughter, and it includes other family members or a friend. So this is a temporary decision maker. If you've not chosen someone in advance, then the medical system will choose that for you. So think, choose, talk. Carmen has really illustrated the importance of having the conversation. Family members are wrong about 30% of the time about the end of life care preferences for their loved ones. So your loved ones and decision makers need to know your wishes. And that may be difficult. In the time of COVID, I think it's easier to have that conversation because we are surrounded by the news every day that talks about how dreadful this disease is. And so it's easy to open up the conversation around, if I ever got COVID, these are the things that are important to me. This is what I would want or not want. But prior to the time of COVID, oftentimes family members found it difficult to have the conversation. And people react negatively sometimes to the whole thought that you might die and that you're prepared to bring up the conversation. And so you have to choose a time and a place where it seems to be appropriate and fitting to do that. I'm reminded of the story of an elderly woman who, realizing how important it was to have the conversation, chose to have it at the dinner table on Christmas Day. Needless to say, it did not go well. And then there's another story of a grandfather celebrating his birthday, probably in his 80s, I believe, who after his birthday party invited his family members into the living room and said, now the best gift that you can give me today on my birthday is a discussion about what's important to me as I look at towards the end of my life. Nobody wanted to have the discussion, but because it was his birthday and his wish, they proceeded to do that. So finding ways to set the stage to have the conversation is really, really helpful. And then it's important that you talk to your healthcare team so that they know most what matters to you. And Carmen, I think you have something that you might want to add here about the importance of talking over your wishes with your physician.
Thanks, Joan. Your point just reminds me of a story when I was actually working back in the US. It was probably 5 years ago now. But it was actually a young woman, and her mother had been brought in by the ambulance and unfortunately had had a massive stroke and had passed away, but she didn't make an ACP, had never talked about it. And so what the healthcare team automatically does is assume that someone wants all the heroic measures, they want everything. So she was, her heart was restarted with medications and chest compressions, and she was put on a ventilator, but there was no signs of any brain activity anymore. And the likelihood of her coming off of the ventilation and having any kind of quality of life beyond a vegetative state was very unlikely. And so I met with her daughter to have this discussion. And her daughter was just, distraught. She's in the middle of grieving, and she just didn't know what to do. And she was faced with the decision of, do I take my mom off the ventilator? Which we also call, do I pull the plug? That's a horrible position to be in as a daughter, as a child, as any loved one or family member when you've never discussed this. And so she was feeling, oh my God, if I tell them to take her off this ventilator, like, am I telling them to kill her? That is how that woman felt, on top of all this grief that she's having and seeing her mom so sick. So my job as her and her mother's healthcare provider in that moment was to be honest about the reality of the situation, about what her mother's life would look like in the future, which was vegetative state, and to take that pressure off of her and to tell her what my recommendation was, which was to remove the life support and to allow her mom to die with dignity and grace. So it's just a story that has always stuck with me. I think just as a fellow human, but as a daughter and a granddaughter, the empathy I felt for that woman in that moment, I can't explain it. Like I felt so terrible for her because it was so hard and it didn't need to be that way. And I think that if they had had those conversations, it would have been much easier for her to be like, oh, I've talked to my mom about this before. I know she would never want to live like this, or no, she would want to live like that. She would want everything. She would have been empowered, and she would have known exactly what to do because she had that guidance, would have had that guidance from her mom. But it wasn't that kind of situation. And unfortunately, that happens all too often.
Mm-hmm. Mm-hmm. And then the next step after having that conversation, and that is a story that is it's more than just a story, it's a real life experience that really illustrates that, Carmen, is to write things down, to record your wishes, your healthcare wishes and your goals, and let your representative and family member know where they are. Keep your documents together in a place that's easily accessible and readily found. These days, the paramedics, if they respond to a 911 call, are used to looking for documents on the side of your fridge, oftentimes in what's called a green sleeve or a green vinyl folder. Reminds me of a scenario that I was a witness to where I was called in to support somebody who was trying to resuscitate his wife who had died. And I asked if there was a do not resuscitate order. And the answer was yes, but it's in the security deposit box. And so it was not available. And that's not where it should be. It needs to be available. People need to know where your papers are. They need to know who your substitute decision maker is. And then you need to revisit your advanced care plan as changes occur in your health status. Your health status is not going to stay the same, and your wishes, your desires, what you want will change accordingly. So make sure that that's written down. There's a wonderful line that comes from the Comox Hospice Advanced Care Planning team. They have t-shirts actually with this logo on them, and I think it's so appropriate. It may be too early, but it's never too late. So that brings us to the conclusion of what we wanted to share with you today. But I think that, Carmen, you have something that you want to add. I think it's a poem.
So this is a poem that was actually recently just written by a very dear friend of mine named Dr. Alexis Stretches. She is a woman I trained with in family medicine who's currently a palliative care fellow at Harvard. And so she's based in Boston, and unfortunately their community has not been as lucky or fortunate as ours when it comes to COVID-19, and they are seeing much more infections and much more death. So this is her poem called View from the COVID Palliative Care Unit. Tired cobblestones slick with spring blossoms, gray and gold rooftops dapple the view. Our collective refuge has left the city quiet, still. I count passing cars plus one lonely plane on my hand, but the ambulance bay fills with too many to ever know or name. Crayon art taped to the unit door flutters, glimpsing the pale face of a new patient. One sign says, "Never be afraid." To my right, a nurse bends her mask's bow, moving slowly. She exhales, testing her eyes, closed like a prayer. Down the hall, my patient says goodbye on Zoom. "I love you," he reaches out. My gloved hand clutches his. By sunrise, his room is sterile again. The lingering smell of bleach and starched sheets unsettles me all day. This pandemic is taking something from us. In truth, I know it's also giving, but the full sum slips now through my fingers. Yesterday, a boy racing his bike yelled, "This is the best day ever." his living crisp and sky blue. I pause, restraining my rage at this coin flip. Look, how close we all are in the communal breath, living under these gray and gold rooftops, separated by the hush of our morning air.
Thank you.
Thank you very much, Carmen and Joan. We have a number of questions that are coming in. Before I do get to them, there was one thing on documentation that has become a symbol of the modern age, is access to accounts and passwords. I know when my aunt died, she was the one who managed all of the household accounts, and my uncle, who had never had to deal with any of that stuff, really had to scramble to figure out how to make it happen, how to pay the utility bills. So there's a lot of practical elements to an advanced care plan that don't have to be really, really difficult medical questions. They can be, what information do people need to know about my life to continue managing it? But we have a number of medical questions. So Carmen, if I could start with a question from a gentleman who says, I am in my 80s, I'm not in very good health. If I develop COVID-19, I don't want to go to the hospital and have a lot of interventions. If I die at home, is that possible? Or if I want to die at home, is that possible? And what would that look like?
I think that's such a great question. That definitely is a possibility. And I think that as long as you as a patient, that's what you want, and you have a caregiver who is prepared and knows what death from COVID-19 can look like and how quickly things can change, and is prepared to help to give medications. I think as long as you are hooked in with the community palliative care team, meaning that there would be nurses coming to your house and likely a nurse available. And we also do have a group of 2 physicians, including myself and one of the nurse practitioners. So we actually have a call group, and we take call a week at a time so that we could be there to help to support death at home for any of our COVID positive or COVID suspect patients. And I think that's something that maybe I didn't touch base with in our presentation, but it is another part of your advanced care plan to think about, especially in the setting of COVID-19, is the location that is acceptable for you to get care. And so is that at home? Do you even want to go to the hospital at all? If what I mentioned to you about passing away at home with COVID and how quickly things can change at home, and needing to have loved ones who are prepared to give care, nurses who are there to give care, and then the on-call physician or nurse practitioner there to support you and ready to give medications quickly and often. That's definitely a possibility. If that's acceptable to you, great. If you still you don't want to go to the hospital, but you don't have a support network like that, you could go potentially to one of the hospice rooms to get that kind of support if one of the rooms is available. And that kind of support could be provided in the hospital as well. And it would just have to be very clear exactly what you want, that you wanted to focus on comfort. The other options, if you were severely ill from COVID-19 for location of care, is going to the hospital, like I mentioned before, but to have more supportive care. So whether that be some oxygen therapy or IV fluids or antibiotics. But if you're getting more sick and we're thinking that, hey, you're going to need a BiPAP mask or CPAP or Airvo, we often start thinking that you're going to need to be transferred to the city if your goal is to be ventilated. So and for a lot of people here, they don't even want to go to the city. So that's something to think about. Where do you want to be to get the care that's acceptable to you? Is it home? Is it the hospital? Are you willing to go to Vancouver or not?
Okay. We have a question about the possible residual effects of COVID disease if you become critically ill with it, and those that would persist into post-recovery and that might be permanent. How would that impact somebody's decision on the degree of care they would receive?
Another really good question. So I think we're learning more about COVID and the residual effects every day. I think that if you didn't have any underlying lung disease or heart disease, you were otherwise healthy before something like this happened, you probably have a better chance of recovering. It's going to take time if you ended up being ventilated. And if you think about the amount of time that people need to be on the vent for, it's typically 10 to 14 days, if not more weeks than that. Your muscles completely get weakened. So you're going to need time with physical therapy, working on your muscles, getting you up and mobile again. They're going to need to help you with your chest to get your breathing back. And it's hard to say what your breathing would be like after that. We don't know a ton about that yet. But with the knowledge that I do have, I think if you were young and healthy, there's potential that you could get back to your baseline for breathing, but there is the worry that you might not. So you might need, inhalers going forward. You might need oxygen therapy going forward. It just depends. And then for someone has underlying disease, like I mentioned before, heart disease, lung disease, older, frail, your chances of being able to recover to your baseline is much less, I'd say. And so with all the physical therapy that you might need, and maybe you're up and walking with a walker, but maybe now you're not able to do that, and now you're wheelchair bound. And maybe, you needed some therapy for your lungs, like inhalers, before you got COVID-19, and now you need oxygen when you go home. So it's really hard to say. So I think you just have to look at how you are at your best, at your baseline, and whether or not your body has the resilience to bounce back. And typically people with chronic diseases, there's much less bounce back.
Right. We've had some questions about having an ACP and how somebody who might have an advanced care plan in place already and they've gone through directives, how their plan might change in the case of COVID disease, as opposed to another health emergency that is somewhere in the future. And then perhaps once you kind of answer that from a practitioner's perspective, Joan, you could speak to kind of reevaluating your ACP and what it takes to change it, how often you should look at it, what factors affect how your advanced directives might change.
So Jackie, I'm not quite clear about what the question is. So you've got an ACP in place, but now in time of COVID, you're wondering about whether you should change it. Is that what the question is?
Yeah, or for a lot of people, they're developing their ACP, they're now in light of COVID and COVID disease, but that might not be, so their wishes now with COVID disease might be one set of directives. They might want to change their ACP afterwards. Yeah.
Right. And because an ACP itself is not a legal document, something called an advanced directive is a legal document, and that's a specific treatment or lack of no treatment in response to a certain condition. But an ACP can be changed anytime. But what's important again is that the person that is going to be speaking for you knows that you've changed and what it is and where your documents are, and that your doctor knows that too. And definitely as people's health conditions change and deteriorate or get better, the things that we want for ourselves change too.
Yeah, I mean, I just echo what Joan just said. It's all about communicating what you want in the different scenarios that could come up. And so, you know, you might say, yeah, you know what, I'm okay with going to the hospital, getting a little bit of oxygen and some IV antibiotics, steroids, that's all fine with me, but I would never want one of those like masks anywhere on my nose, on my face. I don't want that. If I have to get that, no, just give me, you know, that supportive care. And if it doesn't work, then I want to focus on comfort. Where someone, you know, might be, no, I want everything. So it just depends on what is acceptable to you. And I think really thinking about the different scenarios that could evolve given the information that you've been digesting all evening and probably for the past, you know, 2 months. But I think just really clearly laying out, hey, this is what's acceptable to me in scenario A, but if scenario B happens, this is what's acceptable. And if scenario C happens, this is what's acceptable. And I think clearly thinking about it, talking about it and writing it down, as Joan has talked about tonight.
Right. One of the questions that we have is from somebody who's reluctant to bother their doctor with the conversation. How important is it to talk to your doctor? Does my physician really want me to book an appointment to talk about my advanced care plan? Will my doctor be compensated for the conversation? So if you could speak to how important that conversation is.
Oh, that hurts my heart. Yes. Yes, that's our job. We want to hear from you. You know, that's part of our relationship with you. That's part of us being able to advocate for you as your family doc. If you go into the hospital and you see someone who doesn't know you and are trying to figure things out, they call us. They're, hey, this is your patient. They're here. You know, what's their story? Do they want to be do they want to have a full resuscitation or not? Like, what's the story? We have all that. We want to know. And we get compensated just fine. So don't worry about that. We want to have these conversations. We want to have it written in your chart so that we can easily disperse that information to the other people who are going to be part of your healthcare journey if you are to get sick. So yes, please share that information with us. It's so important and we really want to hear about it.
Thank you. I think that's pretty clear. I would say if people have questions, now's a good time to ask because we are drawing to the end of our hour. Let's see, there was one in here. In your experience, there's a question, do people tend to change their minds in the moment of severe illness to want more intervention than they originally thought they would want?
Not in my experience. It's usually the opposite.
Yeah.
I think sometimes the reality of really invasive care, when your baseline might be that you're already suffering in some sort of way, and things aren't getting better with a lot of this extra care, and sometimes it can even be more harmful in some scenarios. I've never seen someone upgrade. I've seen just people simplify their levels of care.
Mm-hmm. And it would be good to hear from both of you in this circumstance. Like, you know, most people, when they're developing an advanced care plan, this is a process of months, even years of kind of going through the process of thinking about what's important, about having the conversations with the people you love, getting paperwork sorted out, and that kind of thing. What are the most important things that people should be doing now with the potentially short time frame? And so if you could speak from a medical perspective, Carmen, and then maybe Joan can answer from a general ACP perspective.
I think really thinking about what you want, and really these aren't easy things to even think about. They're scary. We know about being alive, and our society has kind of made death a really scary thing. And I think just innately we try to stay alive. Like, we're humans, that's our biological thing, you know? So I think really giving yourself space to think about these things that are scary and uncomfortable, and be patient with yourself. Think about your underlying health, your disease, what matters to you, what's acceptable to you, and share that with the people that you love, and pick someone who knows you best to make your healthcare decisions on your behalf based on these conversations and thoughts. Sorry, I feel like I'm kind of repeating myself from before, but that's, yeah, I hope I'm answering the question. If not, please reframe it.
Yeah, well, one question is, how do I register my wishes with my doctor so that it gets into the medical system? So I would say a no CPR form, or a degree of, what degree of intervention urgently that you would want. What kind of forms and paperwork should be in place?
So we have all of these forms pretty much in our electronic medical record. But the things that I think are most important if you want to be a do not resuscitate is getting your BC ambulance form signed, and something called your medical orders of scope of treatment, which is called a MOST form. So that's something that you can go through with your physician that needs your signature for it to be valid in the community. It's a form we use in the hospital all the time that reflects what kind of care is important to you and should be given in the hospital should you not be able to communicate on your own. But it's something that we're slowly transitioning and starting to use in the community now because of COVID-19. So those are the two kind of, there's the BC ambulance do not resuscitate form, and the medical orders of scope of treatment form, so the MOST form. And you can download those off the internet, or you can just go to your physician and get those filled out. And then your representation agreements, if that's something that's important to you, I would get that done.
Yeah.
And if you're someone who is very sick, you have, a severe illness already, and there's no way that you would ever want to go to the hospital or anywhere, and you're going to have the support that you need to support a home death, there's something called an expected death in the home form. And that's really so that if you pass away at home, it says this was expected. We don't need to get the coroner involved. You don't need anyone to come and pronounce that you've passed away. This is expected. And it's more for communication with the funeral home. So those few forms.
Yeah. I can see a lot of people saying, where do I get this and where do I get that? And I just want to assure everybody who's watching that we will have a document available on our website and linked in through Facebook that will give you all of the links that we've talked about tonight. I was just waiting to see if other things came up before I actually post it. So I would say give us until tomorrow afternoon, but it should be there or on Facebook. So don't worry about where you're going to find things.
Yeah, don't worry about that. Your family physician has it at their office too. So
yeah, your family physician has those. And somebody had said, does a DNR have to be signed by my GP? And I believe the answer is yes.
Yes, it does.
Yeah.
Yeah.
Yeah. And
Jackie, could I just interject something?
Mm-hmm, please.
The question about that Carmen answered around what's important or how you view what you would want or moving forward. I think it really comes down to, and we haven't used those terms, but it really comes down to quantity of life versus quality. How long do you want to live? And sometimes that's quite compromised. Or do you want a rich, full life until the point where that's no longer possible, and then you're quite willing to say, I'm going to let go. And some of that is also dependent upon what your views and beliefs are about death, about what happens when you die. Or how prepared you are for that. So those are two important considerations. And quality of life changes depending upon the circumstances as well, of course.
Mm-hmm. Yeah. Yeah. When I was saying earlier in this weird COVID time, what's important, Carmen, I wonder if you could speak to how important it is simply to have the conversation with your family.
So important. I think some of my earlier stories kind of highlight that. Yeah, this is an important conversation in my opinion, no matter what. But COVID-19 is really, I think, lighting a fire under our butts, and we got to have these conversations because this is super contagious. It can make you really sick. It can make you lose your voice really fast. So the sooner you have these conversations, in my opinion, the better.
I'd like to just share a personal story that highlights that too. It's the story about my mother. My mother, who died in 1992. She had had open heart surgery for a valve replacement and had a very difficult recovery, was in ICU for quite some time, and then prior to discharge from the hospital had another heart attack. When she came home, she was quite weak and feeble, but over the months between February and October, she gained her strength back and she was doing fairly well. One evening in October, she wasn't feeling well and she went and lay down. Her husband went to check on her a short while later. This would be my stepfather. She had died. And he called 911. And they came and they resuscitated her. And she died again in the ambulance or at the hospital. I'm not sure which. And I've often thought about that scenario. Around the dinner table, the many opportunities we had to talk to my mother after she had recovered from surgery and say, what would you want? What would be important to you if something should happen again and you had another heart attack? And what a much more dignified exit she could have had that conversation occurred. But it didn't, and it really highlighted for me again the real importance of having that talk with those people that you love.
Mm-hmm.
Yeah, and I think, even I'm a family physician. I love palliative care, do a lot of it, and I have these conversations all the time with patients and families. And it's still hard for me to even have these conversations with my parents. So I don't think anyone is alone in feeling that kind of hesitation. It's something that it's really hard to think about your family member, loved one, like being really sick or passing away. Mm-hmm. We all hate thinking about that, but it's better to have these conversations now when the stage is set, like you said. Like, it's not a stressful in the hospital chaos. It's you're sitting down, you can have a tea or coffee, birthday cake, whatever it is, mm-hmm. but do it in a nice setting that's controlled, as opposed to in the hospital where things are totally out of your control.
Yeah. I think personally that it's probably one of the most compassionate things that you can do for your family members, to let them know where you stand so that they don't have to try and put themselves in your head and think for you, that they just know because you've told them what your thresholds are, whether you want to fight with every tool in the box or whether you want to go gently. Yeah. I know there are a few other questions, but I can see that our time is running out. Again, I wanted to reassure everybody that we are going to have all of these links available on our website and linked into our Facebook page. And if you have other questions that you want to pose to us, please feel free to send them to us either by email at info@coasthospice.com or via our Facebook page, private message, or in comments below the webinar. And if we can get easy answers together for you, we will. And if we can incorporate some of the questions that you have into another smaller, more interactive workshop, then that's something that we would consider doing. Yeah, so there will be information and links available on the website. And so I would really like to thank our two panelists for contributing their time and expertise tonight. And also to let you know that events like this take a team of people and are made possible because of the hard work of our dedicated volunteers and staff, and only with the support of our friends and our community. So if you would like to get involved with hospice and support our work, please go to our website for more information. I will post the contact information as this webinar ends so that you can see it written down. And I just want to thank you all for sharing your evening with us and wish you a good night.
Thanks, everybody.
Thank you.
Thank you.